Hi everyone, I want to talk about fractional excretion of sodium. Sit back, let's go. Fractional excretion of sodium. Fractional excretion of sodium could be mathematically expressed as this. You can pause and look at it again. That will measure the percentage of fetal sodium that is excreted in the urine. There are a lot of drawbacks, okay? Why? Fractional excretion of sodium threshold is variable. The value may be low because there are many factors that could cause the low level besides the pre-renal causes. You can be faced with renal salt wasting, and that will increase the value. And if someone is using diuretics, that will also alter the value. In that wise, you can use the value of urea in the face of active diuretics when the excretion of sodium will not be low. Okay, so we use fractional excretion of urea in those taking diuretics because diuretics will increase sodium in urine, and that will raise the value of fractional excretion of sodium above the level that will make us determine pre-renal cause or causes of acute kidney injury. Uses. Fractional excretion of sodium will assist in distinguishing pre-renal causes of acute kidney injury from acute tubular necrosis. Remember that severe pre-renal causes in the face of hypotension will actually lead to acute tubular necrosis. We can also determine the pre-renal causes if we can't use sodium fractional excretion value. We can use that of urea, lithium, and uric acid. Remember that we can't use fractional excretion of sodium alone to accurately determine pre-renal causes of acute kidney injury. FENa less than 1% is expected to mean pre-renal causes, right? But that is not diagnostic. If it is greater than 1 to 2, it is pointing to acute tubular necrosis or renal origin. FENa are lower in patients with less severe disease due to renal or acute tubular necrosis. So don't jump at the conclusion that this value that is less than 1 is always pre-renal. No, it might be due to less severe renal causes or less severe acute tubular necrosis. In acute tubular necrosis, it's likely that you get a very high fractional excretion of sodium due to inappropriate sodium wasting or preserved nephrons that are responding to volume expansion. What are the limitations? Fractional excretion of sodium less than 1% can be used to diagnose pre-renal acute kidney injury unless there is marked reduction in estimated glomerular filtration rate. So, the doctor that will be at safer end will have both fractional excretion of sodion on one hand, then estimated glomerular filtration rate the other hand, and match the two. Single measurement of serum creatinine may not give the true picture of the estimated glomerular filtration rate. Fractional excretion of sodium can be less than 1%, but pre-renal disease is not the only cause or causes of acute kidney injury without value. It can be greater than 1% when the pre-renal disease occurs in chronic kidney disease. Did you hear me well? Okay? It can be greater than 1%, yet it is pre-renal, but in the face of chronic kidney disease. Or any cause of sodium wasting. For example, it is pre-renal, but in the face of active diuretics. Yet the value is greater than 1%. Other causes of acute kidney injury with fractional excretion of sodium less than 1% could be post-ischemia acute tubular necrosis. Because no, some believe that once the value is less than 1%, it is pre-renal. What if it is acute tubular necrosis, post-ischemic phase, evaluated early while transmitting from pre-renal to acute tubular necrosis? What about superimposed acute tubular necrosis upon a chronic pre-renal disease? Or 10% of non-oliguric acute tubular necrosis with less severe disease. So you are dealing with acute tubular necrosis, but the value is low, it's less than 1%. Acute tubular necrosis with early sepsis can give that. Also, with radio contrast media can give that. Acute glomerulonephritis or vasculitis can also give less than 1%. Acute interstitial nephritis can give that. How about acute urinary tract obstruction? It can also give that. And it's post-renal. Remember that it can be pre-renal, but fractional excretion of sodium will be greater than 1% if on diuretics. You can use fractional excretion of urea, lithium, or uric acid. If it's less than 1%, we expect that to be pre-renal, but remember everything I've said before now. If it's greater than 1 to 2%, we assume that to be renal or acute tubular necrosis. Sometimes it could be intermediate. And in that wise, if it is less, that is pointing to early obstruction. So it's going to be less in early obstruction in post-renal. It's going to be greater in obstruction with kidney damage. You have to rule out the following: burns, renal transplant rejection, non-oliguric renal failure, heart failure, liver failure, acute glomerulonephritis, pigment nephropathy, contrast nephropathy, polyuric renal failure. In conclusion, please check my channel while interpreting your fractional excretion of sodium values. And remember, if you are confused, get estimated glomerular filtration rate. Also remember, one value of creatinine is not enough to give you a good picture of estimated glomerular filtration rate. And also remember that you can also make use of fractional excretion of urea, lithium, and uric acid. And the value lower than 1% doesn't mean it's always pre-renal. Thanks for listening. Remember to share and remember to subscribe. Thanks, I appreciate it.